Jeff stops and takes the trash for a second. You move on. And that could be just someone who wants to feel skeletal, ask them if there's on it.
So we apologize that this month we are not able to provide continuing medical education. We're in a little bit of a hiccup point. We're working that out with, hopefully with UC Davis, with Dr. Tom Balsba's assistance. We'll bring that back on board. But we have, so UC Davis, who's just arrived in the room, is working with Dr. Susan Ivey to get the continuing medical education reestablished for this group. Thank you all for being here. We have a very large group today of over 60 people, and we have an amazing agenda, amazing survivor's story. And with that, I'm going to say we don't have time to go around the room and do introductions because we have too large a crowd with too packed an agenda. So I'll just say thank you, Dr. Revlo, for introducing our first speaker, and thank you all for being here today to help save lives.
Thank you, Hattie. Yeah, it was a great group here today, and I'm really excited and honored to be able to introduce Mr. Sean Maloney, who is coming to us from Silicon Valley, and actually coming from a little jet lag, came in from Africa, so not only is it the travels in Silicon Valley, but traveling all the way from Africa to join us is wonderful. So, Mr. Maloney is, as you can see, is a retired executive vice president for Intel Corporation and is a board member of the American Heart Association. He's a stroke survivor, and you can see his brief bio that he shared with us in your packet. But what I'd like to basically point out is that he is a gentleman who has been healthy all his life and did everything positive to continue his health, and yet in spite of that, unfortunately, he suffered a significant stroke, and that led to his desire to be able to share his story with both professionals like us, as well as consumers and patients, on this very significant issue that can confront all of us at any time, any second, and the impact that this has. We're really grateful that you're willing to share your story, and you can read that Mr. Maloney has also served on the board of directors, like I said, of the American Heart Association, the Silicon Valley chapter, also in several large corporations that include Nematome and Cumulus 9, and is advisor to Cephan Sonics and Silk Road Medical. And with all of his experience coming in, and especially his personal experience, I'm happy to introduce Mr. Maloney.
Thank you. Thank you, Jose, and thank you all of you for inviting me to speak to you at the University of Best Practices. As a stroke survivor with aphasia, to be able to address you is fantastic. Let me talk about something that happened 6 years ago. We at Intel had just survived the worldwide financial meltdown, and we were poised to have a great year. Some of the company's board and my boss were supporting me to become the next CEO of Intel. 2 months before, my wife and I had my youngest daughter. I have 6 kids. 5 daughters. I was planning a future where technology would continue to change the world for better for our children. It was February the 23rd, 2010. On Sunday, I began my day at 6 a.m. rowing on the bay. The sound of water, the jumping seals, it was wonderful times. I came back home, had my coffee. Later on, I went for a run. I raced my son up Stanford Dish, which is a hilly 3-mile path. When it ended, I started to feel funny. I told my son I will have to go and lie down. I walked up to my bedroom, walked over to the bed, and then that is when my stroke happened. A piece of my blocked carotid artery broke off and became lodged in my brain. I collapsed on the bed. Funnily enough, I thought my life was over. A strange feeling of peace passed through me because I thought I was going to die. When I came to my senses, I was in the emergency room at Stanford Hospital. My wife was at my side, but fortunately I could not speak. The neurologist tried to do TPA, but it was, I went into the emergency room 20 minutes after my stroke, but the TPA was 10 hours after my stroke, right? Luckily, however, my ability to read and think was intact, and I recognized my family. We all know not being able to talk is a real problem, but for this Irish Englishman, known for the gift of the gab, this was particularly disconcerting. Unfortunately, as my stroke flowered over the course of the next following day, I could hardly lift my right hand, and I could only say 2 words. These were no and yeah. I was an Englishman, and I couldn't even say yes. Needless to say, the doctors weren't very optimistic about me. A number of the staff also treated me like I was stupid. The week after the stroke, I went out of my room into the ward. A male member of staff rushed up to me like a prison guard, and he said, "You are not allowed to be here." Then he ordered me back. "Go back into your room now." I was an intelligent man over the age of 50, and yet I could not explain the most basic concept that I was going stir crazy in my room, and I just needed a little time outside of it. Unable to explain myself, I laughed and laughed and laughed because of the frustration and irony. So I couldn't move my right arm, but I dragged my left foot and still only had a vocabulary of 10 words. My family said that if they ever hear me say "wow" again, a word I would never said before the stroke, they would be happy. Little by little, I started to make myself clearer. Needless to say, I was the most difficult patient in the rehabilitation room and broke through a number of times before being out a few weeks later. There were times when I was down, when I was really, really down. I ignored the negative comments and doom-saying doctors. I have to make incredible efforts in order to speak again. Frankly, it has been the most difficult thing I've ever done. Running an organisation with 11,000 people and negotiating with the tougher business leaders, Steve Jobs, is nothing in comparison. I was told by my doctors that I would never be able to go back to my previous level, yet a year after my stroke I returned to Intel, and a few months after I was made chairman of Intel China. 4 years later, on March 2016, for the 5th anniversary of my stroke, I embarked on Heart Across America campaign, cycling over 5,000 miles from Palo Alto to New York. Along the way, 500 cyclists rose to raise money for the stroke and heart disease prevention and to raise funds for the American Heart Association. The second time, I will say mea culpa. I had 3 weeks after the starting line, I had an accident on the road. I was going along at 35 miles an hour and I crashed. I dislocated my shoulder, broke a few ribs and fractured my hip socket. But anyway, the ride carried on, right? At the end, we were riding into the finish line with the rest of the team. We raised over $330,000 for the American Heart Association. We held events in 14 states, educated hundreds of thousands of Americans on stroke and heart disease prevention. It's very good. For any of you here today who have patients or family or friends who are recovering, I urge you to tell them, never give up, never ever give up. Anything is possible if you continue to believe it is. If you continue to be working at it. Optimism and sheer determination are essential for our recovery. The next few years have been this will be a promising time for stroke recovery. 2 points. I've spoken to hundreds of thousands of people all the way across America. when I go into the room, let's say there were maybe 100 people there, I will say to them, I've had a stroke. You don't want to have a stroke. You don't want to have a stroke or a heart attack. Go to the get your blood pressure checked. You get your cholesterol checked. Trust me, I'm going like this. Get your blood checked, and in the evening, lots of people are saying to their wife, God, or husband, God, I've got to get my blood pressure checked. The following day, work happens. The following week, work happens. No one has, or maybe 5% will do that. It's going to go away because it's going to go away. So actually, me saying you are having a lot of strokes in the next 5 years. You are having a lot of strokes in the next 5 years. Sorry, but that's the way it is. The second point is that early detection really works. Early detection with CT scans or ultrasound scans really works. Framing hand does not work. When I was looking at if I could be president next year, right? I couldn't be president because I was born in the UK. But if I could be president in next year, all the way look at America. $1 billion a day, $1 billion a day gets spent on stroke and heart disease expenses. $1 billion a day. Oh God, $1 billion a day. That's right up on the and if early prevention works, we've got to do that. We've got to do that. So that's me. And thank you very much.
May I ask you a question?
Yeah.
So when we were meeting prior, and I asked, did you have high blood pressure?
Yeah. Of course I've had high blood pressure, but I was rowing, and I said to my doctor, is it going to affect my running? And she said, and I said, okay, I won't have it.
So
bad news.
So
Bad
my
news.
request to you, Sean, is if you could please add in to your remarks to the public how important it is to control the blood pressure.
Yeah, I do, yeah.
Because if your doctor, if somehow the public messages would have explained to you that hypertension, high blood pressure could have sent you into this state, you would have taken her advice to take medication so much more seriously.
Well, no. I knew about high blood pressure, and it was fine. Maybe I had high blood pressure once a day, but it's fine. Bad news, I've got to get the blood pressure down, and I didn't, and that is why I had my stroke. I didn't. and that is why I had my stroke.
So
I have mentioned it.
So these two guys, this is Dr. Revlo from Center IPA, and he worked with Dr. Ivy and Dr. Erdl and Dr. Firmison, Dr. Balsbaugh, many of the doctors in this room, to create this simple tool to help the doctors help the patients to have better control of blood pressure. And I think that what we've been asking the public health community to do is help with the messaging to the general public so that people better understand the consequences of not controlling it. People don't understand because there are no symptoms of it. But I want you to know these doctors are working really hard to improve it for the patients.
Yeah, I'm really glad, but I was too stupid. You know, I was too stupid, and I rode. You know,
You weren't stupid.
Yeah.
You didn't get the information in a way that was compelling
Well,
to
maybe.
you. So you're going to save a lot of lives by telling your story, and I hope that you'll tell the story that the part of it is that you did have high blood pressure that you didn't choose to take medication for.
Yeah.
And you know, many patients make the same choice, which we can see in this data that everybody has in their packets, that even for diabetics who have twice the rate of heart attacks and strokes, we have a very small percentage of them with good control of blood pressure. There's only so much the doctors can do, and there's a lot more that they can do. Like Dr. Erdl did a survey, started a survey that's now been spread across the state to say, how are we implementing the scientific guidelines? Do we know that we need to treat African American hypertension differently? And by getting the precise data about which doctors are doing a good job, they can get the doctors to do their part. But we, by partnering with you, can help get the patients to understand the messages.
Right. Okay, thank you.
That was great. I really enjoyed that. But we want to talk, and our next talk is going to be talking about TPA 10 hours later, and not do that anymore. So it's a wonderful story that Jim and Alan have to present to us today. But recognition of hypertension is one of those things that we can do a better job as health systems and health and physicians. That's one of the things that we're working on. You know, how do we get data in front of the physicians that say you're not doing that great a job with controlling blood pressure? You know, we in our system, we're with Mercy Medical Group, we have 2,000 patients that have blood pressure readings that are what would be considered hypertensive, but are not identified as hypertensive patients. And that's on us. That's on the physicians. So we need to do a much better job. And so I think that doing better population health, better job on hypertension control, under control is great. But as you said, in the next 5 years, you're going to have a lot of strokes. And so how do we deal with that? So I'm going to be very brief in my introduction. Jim Roxburgh and Alan Schatzel, they're good friends of mine. The accolades, I don't know where to start or stop because there are many, but they have shepherded this telehealth network, the telestroke network, from 4 to 48 sites, and it does exactly that. Patients that present with a stroke are recognized early. The ED physician has a neurologist to hold their hand within 5 minutes to go through the stroke protocol and give them TPA in very short order, which saves brain, and that's exactly what they do. Dr. Schatzel is triple boarded in various aspects of neurology and sleep medicine and neurophysiology. Jim has 3 degrees, RT, RN, an undergraduate degree, and a master's in public administration, is that correct? So just as an aside, Dr. Schatzel is currently president of Mercy Medical Group. Jim is a 5th degree black belt in Taekwondo, and he's a trained cage fighter. And that really helps to get this work done. So please welcome Dr. Alan Schatzel.
Well, thank you, Dr. Erdl. Appreciate the introduction. Mr. Maloney, thank you for sharing your story. The last time I was here to present, and I appreciate being invited again to present, I had talked about a neighbor of mine who had a stroke in my home. And as a neurologist who spends all their time providing care in emergency rooms and taking care of hyperacute scenarios, it's quite different when it's in your own home. But getting the message out there, talking about prevention, talking about recognition of symptoms is really important, and I appreciate you sharing your story and getting the message out there. We have no conflicts to disclose. Our learning objectives are also on the paperwork there. We wanted to talk about what we've done through Guinea Health Telemedicine Network, talk about some of the principles and the paradigm shifts and how we're moving more into the prevention. I've spent the last 12 years of my career serving the emergency rooms, making sure that people get the right care at the right time, at the time that they need it. And now I'm recognizing more and more that prevention is the key, prevention is the answer. Because the more we can keep people out of our emergency rooms, the more that we can keep people from having strokes and heart disease and heart attacks, the better off we'll all be in the long run. So I'm going to talk about some things that we've learned over the years. Jim's going to talk about some service models that we've developed, not only on the hyperacute side, but now how it's all poured across the continuum of care. Now how we're in homes and we're trying to provide monitoring to, again, aid in the prevention and reduce our need for emergency type systems like we've developed. And hopefully at the end here you'll think about future medicine and where we're heading and how we're all part of this and working together is going to continue to push us forward. First we need to talk about where we started. Guinea Health Telemedicine Network started with an idea that came from a great stroke nurse and neuroscience leader, Deidre Wentworth. Deidre was giving a community forum lecture talking about stroke care and the importance of providing stroke care in emergency rooms. And at the end of her lecture, somebody from the Elliott Holmes Foundation came and approached her. The matriarch of the Elliott Holmes family had suffered a stroke. They had recognized that there was opportunities for improvement in stroke systems of care, and because of what they heard through Deidre, they wanted to support some type of effort to improve stroke care. Deidre was the one that had the idea of connecting a core group of highly experienced, highly proficient stroke neurologists in downtown Sacramento to a suburban community hospital out in Folsom, Mercy Hospital, Folsom. And Elliott Holmes provided the $500,000 seed money that led to that telemedicine connection, that virtual connection between Mercy General Hospital and Mercy Hospital Folsom, which has now led to, as Dr. Earle had mentioned, 48 partner sites throughout California as we're continuing to improve systems and has evolved into many other services beyond just hyperacute stroke care. From the very beginning, our program's been all about timely access to care, providing high-quality specialized care and healthcare services where they're otherwise not readily available. Our guiding principles that we've developed over time include these concepts. All patients deserve high quality and timely care regardless of location. All patients deserve access to the most proficient and experienced specialty physicians regardless of location. Reliable, consistent access to experienced, proficient specialty physician drives quality and outcomes. Reliable, consistent access to experienced, proficient specialty physicians reduces liability and risk for physicians and the hospitals where the services are needed. And then our mission is simple, deliver compassionate, high quality, affordable healthcare services anywhere, anytime. We've recognized over time that the benefits of telehealth include access, service, and quality, and that drives value. We all understand that now. We've also seen our ability to recruit, retain physicians, allocate our resources across the large hospital system, develop sustainable practice models, and better manage our population. And from the beginning, we've tried to boil it down to the simplest element, which is services being provided to patients, and thinking about service first, service always, and connecting with patients is how we've succeeded. Through telehealth, we're able to drive costs out of the system, by providing the right care at the right time, developing integrated systems of care, and growing smart and providing high quality care helps provide satisfaction for our patients. Michael Porter is one of the thought leaders at Mass General who thinks about value-based systems of care. And if you think about it, telehealth systems are what are going to get us to this point where we're so highly integrated that we're able to provide necessary services, and the interdependency between all the connections is what yields the ultimate outcome, the high quality, lower cost, and high values. Stroke, we all know, is the #1 cause of long-term disability in our country. We've had some success in moving it to the 5th leading cause of death in the U.S. But still, every 45 seconds somebody's having a stroke, every 4 minutes someone's dying from stroke. More than 795,000 Americans are having a stroke per year. 167,000 will not survive the stroke, and this is a great cost to our system. I'm an overseas fellow for the Royal Society of Medicine. In 2013, November, I was attending a meeting there, and they were talking about telehealth systems of care, what they're doing to provide better services throughout the UK. I went this November as well, November 2015, and I have family in Ireland actually, so I went over and visited Ireland on that trip. And it started me thinking about what's different about different systems of care throughout the world. And what I found when I went and dug deep into it is not a whole lot of difference actually. UK and Ireland, despite being a nationalized system, you would think they'd have great controls and ability to provide necessary services. When they did an audit of their system back in late 2000, they were struggling just as much as the US would. And they found that their services were not adequate, and there was an avoidable death per day throughout their national system. From that point forward, they really strived and pushed telemedicine services, and they're better than they were, but they're still struggling, as we all are, to continue to develop and improve and do the best we can for our patients in need. Ireland has a big problem. They have they have high density, big cities, but a lot of vast territory in between. It's on a much larger scale than the U.S., but we have the same problem. We have high density centers where most of the physicians flock to provide necessary services, and then we have lots of gaps in between, and this is where telehealth, I think, is one of the big answers for us. This is a slide I shared in my last presentation here. You can see that the stroke death rates are highest in communities that are most underserved, and you'll see how the medically underserved populations and stroke death rates kind of go hand in hand. There's a map later, I want you to remember these maps, there's a map later that will also overlay on top of this, related to atrial fibrillation. In the United States, we like wide open roads, we like our freedom, but in experiencing that freedom, you may pay the price because you may be a distant location from a center where comprehensive services are available to treat you in a timely manner. So again, how do we connect everything together? How do we connect all these critical access hospitals and all community hospitals through telemedicine services to provide the best care possible at the time when it's needed most? So when Ireland was doing their stroke audit, the United States was going through a similar type of audit through the American Heart and Stroke Association, and it was very well recognized that there was a disparity in stroke care. Only 2 to 8% of people that suffered stroke were getting IV thrombolytic therapy. Over 64% of our hospitals did not even treat with IV TPA in over a 2-year period of time. Approximately 4 neurologists per 100,000 persons in the United States, which is clearly not enough neurologists. But the other challenge we have here, and I'll make a point on this later too, of the 4 per 100,000, there's probably only 1.5 neurologists per 100,000 who actually do hyperacute emergency neurology and stroke care, which is an increasing problem for us. Many are subspecialty trained, prefer to spend time in their clinics and have to spend extra time in their clinics and aren't available for the emergency services, which is where telehealth services and telemedicine comes in to help even out the playing field. And then there's a big problem when you don't have the experts at the bedside, because misdiagnosis which is the same that they found in Ireland's audit, is a big problem. We know through the research that was done at UCLA with Dr. Saber's group that 1.9 million neurons per minute are dying when a blood vessel is closed, 14 billion synapses, 7.5 million myelinated fibers. Time is of the essence. This is why American Heart, American Stroke came out with the Target Stroke Initiative. This is the goal of more than half of everyone who comes to the emergency room who's eligible for thrombolytic therapy gets TPA within 60 minutes. We're now moving the bar on this. We're now targeting 45 minutes, and most of our stroke centers we're working with are hitting their 50% less than 60 minutes, and some of them are at the elite status. So again, back in 2009, American Stroke Association came out with this recommendation that telestroke networks should be deployed wherever a lack of readily available stroke expertise prevents patients in a given community from accessing a primary stroke center within a reasonable distance or travel time to permit the eligibility of IV thrombolytic therapy. We've, over time, recognized how this is all connected together in the quadruple lane now, right? Where we want to have an enabled system that's ready to provide the care necessary, make sure patients have the best experience possible, that our population is well cared for, and we provide it at a lower cost. There's some people that have this idea that giving thrombolytic therapy for strokes is a high cost type of phenomena, or providing interventional services high cost. I'll later show a few slides where that's the opposite case. Everyone knows Don Berwick, I think, Crossing Quality Chatham, Institute of Healthcare Improvement. And Dr. Berwick said, every system is perfectly designed to get the results it gets. And with this in mind, that's why we're redesigning our systems. That's why we're inventing and integrating and innovating in order to provide the best care possible and achieve these 6 aims of safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Adam Darkins, who Mr. Maloney may know, is Chief Consultant of Coordinated Services of our Department of Veterans Affairs, and he was one of the speakers when I was at the Royal Society of Medicine UK in 2013, and he was coming back to UK, which was his homeland, to become a Chief Consultant for their telemedicine systems as well. And his comments about telemedicine, I think, were great. He didn't have PowerPoint slides, he stood at the podium, gave a great speech. And he basically made these points. Telehealth is not about the box or the cloud, okay? It's about problem solving and service delivery. It's about creating large networks to enhance access, improve service, improve quality, and distribute knowledge. Healthcare systems unfortunately value the intervention, not necessarily the right decision. There are people who are best suited to make the right decision at the right time every time, and telehealth systems of care is how we accomplish that. I promised to show you a few slides about the cost effectiveness of thrombolytic therapy. This is well described in our neurology literature, and Canada understands this very well, which is a system of care is a nationalized health system. And their challenge lies in improving access to thrombolysis, because it is a high rate indicator of best practice for stroke care. And they know that if they're able to deliver services, that the more patients who receive thrombolytic therapy, who are eligible for therapy, actually drives a lot more cost savings in their system of care. So, as you saw earlier, most of our hospitals are between 2 and 4, maybe as much as 6%. Most high-performing stroke centers, like our stroke center and other great stroke centers in town here, are approaching 20 or 20+% thrombolytic therapy. And that's not only reducing disability, that's improving our cost of care in our society. This is just another same slide showing the United States and California what the potential cost savings are with each incremental gain in thrombolysis. This slide's a little strange, and it's again to make the same point I made earlier. So it's becoming increasingly difficult to find well-trained, highly skilled neurologists to provide the emergency services and hyperacute type of hyperacute stroke scenarios we need to care for. They're becoming rare, just like these, the greater bamboo lemur and the northern hairy-nosed wombats. So at the very time where our population is growing, we're having more and more people that may be suffering emergencies and stroke care. our projections of who's going to serve their needs is dropping. Another challenge we have is physicians want a better work-life balance. They want to have a better lifestyle. It's putting added pressure on our systems of care. Again, I point these things out because I think telemedicine is becoming a requisite in developing our systems and in providing the best care possible for our patients. These are the length of time people are waiting for appointments. At the same time that our need for stroke and heart disease, cardiovascular disease is rising exponentially, we're having fewer physicians who can serve their needs. This is my slide from my previous talk here, where I talked about robots' responsiveness and reliability and the economic impact of organized systems of care. I mentioned that our hospital systems, unfortunately, are developed on old technology, outdated technology. Our systems have come a long way. Most of us now have very advanced, secure Wi-Fi networks and capabilities. Still, though, we have siloed type of arrangements across systems where there's oftentimes one hospital across town from the other hospital is competing with each other. There's a certain independence, and my role as a community leader to provide medical services is try to figure out how to knock down all these silos, get everyone working together. We've been fairly successful at this because we've been able to use our telemedicine network to kind of even out the service delivery and lower the landscape or even out the landscape so everyone gets the same care regardless. It's one big ecosystem inside of this bubble, so to speak. We know that not every system is prepared or not every hospital has the most comprehensive services. We have a comprehensive center here in the Sacramento region. So what we do is we use our telemedicine network to identify people who need hyperacute evaluation and thrombolytic therapy, but also may benefit from neurointervention capabilities, which is now, within the last year and a half, has become the standard of care in the stroke world, where it's no longer good enough to just identify someone and give thrombolytic therapy. You need to understand that they could benefit from a neurointervention. You need to get them to a comprehensive center where they could potentially get that neurointervention successfully completed. So this is kind of an out there thing. This is another presentation I prepared. But hopefully others will kind of understand what I'm trying to communicate here. So thinking forward, what we need to accomplish in our health systems of care, we need to achieve interdependence. We need to have everything connected. So how do we lead that change? We think about, from quantum physics, there's some terminology where this actually means how great or how much. But the quantum realm is a non-local environment. Everything's connected, okay? And there's this interconnectedness that makes this quantum entanglement. And then in this big entangled environment, information is exchanged freely and it acts as one system, not separate entities kind of competing against each other. And when I sit back and I think about that, and I try to understand how we could benefit from what they've learned in quantum physics, it's like, why not? Let's do it. Let's get it all connected. Let's make it happen. Through telemedicine, basically what we're doing is we're compressing time and space, right? We're allowing people to be somewhere where they otherwise wouldn't be physically, where they wouldn't be personally, but you're able to use their knowledge and use their expertise hundreds and thousands of miles away. We're doing this every day. Every 45 minutes we got a hyperacute scenario that's coming up and we're responding. We're at the bedside in a couple minutes and we got to keep expanding this and keep improving this. I don't know where we are on time, but I'm going to switch gears a little bit here because what I want to do is kind of stimulate everyone's thinking about prevention of stroke. Okay? Because that's, again, I spent the last more than a decade thinking about these hyperacute stroke scenarios, and now I want to rebrand myself as a stroke preventionist because I know that's where all the value is. If we can prevent stroke, that's really where we can make the big difference.
So just to answer your question on time, you and Jim Roxburgh have another 30 minutes.
Oh, perfect. Okay. Thank you. Jimmy needs like 20, right? Okay. So these are slides from the American Heart and American Stroke Association. This is the writing committee that helped bring these together, and these are the two people specifically who will bring the slide deck together. And it's not the complete slide deck. What I did is I selected areas out of this, again, to think about as a community through the University Best Practice and the Right Care Initiative, what things can we focus on and work together, find synergy to really make a huge difference in the stroke prevention world. This is just a reminder of the different classes of evidence, and Class 1 Level A evidence is the highest tier. And then this is a grid that also shows, multiple randomized controlled trials are the Class 1 Level A. And then if there's a randomized controlled trial or several other studies, it drops down from there. We know that the risk of stroke, they're well documented: hypertension, diabetes, atrial fibrillation, and some of the top few. And there's some less well documented that I'll touch on a few of those, but I'll not be exhaustive in all of this presentation. In hypertension, we know if we are able to identify patients who have high blood pressure, specifically those may also have glycemic control issues, that if we provide them with the necessary treatment, we are hitting the highest level of evidence for providing prevention. Cigarette smoking has a Class 1 Level B. There's a big initiative right now through the American Heart, American Stroke Association, where we're looking at tobacco reform legislation to try to reduce initiation of smoking among teens and young adults, and also trying to better regulate smokeless or the vaporizers and these type of things. So, of course, diabetes, better glycemic control, class 1 Level A evidence, and not only just controlling the blood sugars, but the blood pressure management in these patients is critically important. And this is all on the dashboard with the UBC, the University Best Practices. Atrial fibrillation, I think, is an area where we all know there can be better awareness, a better understanding about the risk. There are a lot of people who I think have irregular rhythm and feel kind of funny, but then it goes away and they feel like they're going to be fine. Maybe they mention it to their doctor, maybe they don't. And I think the more we can help people understand the risk of having this type of problem and not being on the appropriate medications for prevention of stroke, the better off everyone will be. Diet and nutrition, Level 1 evidence A, evidence for reducing sodium. Physical activity is a big problem, and again, just encouraging everyone to be physically active. Obesity and body fat distribution, if our patients are overweight or obese, weight reduction is highly recommended, also to help with their blood pressure, and that's Class 1 Level A evidence. There's a whole host of less well-documented, potentially modifiable risk factors. I'm just going to hit a few of these. Alcohol consumption. If we can get our patients to reduce or eliminate alcohol consumption, we know that that can help prevent stroke, and that's Class 1 Level A evidence. Sleep disorder breathing, as Dr. Earl mentioned, I'm a board certified sleep medicine as well. So because there's so many things that are tied together with chronic sleep deprivation and untreated sleep apnea, there's Class 1 Level A evidence for identifying patients who may have untreated, undiagnosed sleep disorder breathing and get them appropriately treated. Aspirin for the primary prevention of stroke. Other risk factors for stroke, Class 1 Level A evidence that each patient should undergo an assessment for stroke risk. And this may include screening for carotid disease and make sure we're auscultating for bruits and understanding and getting screening ECGs for AFib.
May I ask you a question?
Sure.
We were talking earlier about the use of ultrasound for the carotid artery.
Yeah.
Can you talk about when is that appropriate, and when is that appropriate, and what age?
Yeah, I mean, right now it's Class 2B evidence actually, so it's not 100% clear who and when. Certainly, if somebody is getting a good clinical exam, someone has a carotid bruit, definitely a carotid duplex is the right thing to do. I think this is an area where there maybe needs to be more focus of trying to understand exactly who do we identify to go through carotid, echo, aortic screening, right? And I'm not aware of off the top of my head, I'm not aware of anything specific that says if you have these 3 things, you should go through this type of screening. If you don't, you shouldn't. If someone's a smoker, hypertensive, diabetes, high cholesterol, I think a lot of the clinicians would do a really good clinical exam and maybe even send them for a cardiac.
What about family history, and can a stethoscope pick up what an ultrasound can?
The answer to your second question is no. I mean, they've shown that identifying carotid stenosis through auscultation is about a 50-50 shot, although it's still the best practice to listen for carotid bruits. 2, family history, I'm not aware of anything related to family history in carotid screening with duplex. I wanted to talk a little bit about a little bit more about atrial fibrillation, because I think that's a really good area where everyone can focus a lot of attention. This is just showing the normal heart conductivity system, and this is just a cartoon of showing what happens in atrial fibrillation, where you get this, kind of abnormal circulation in the atria and can form a clot, which then can dislodge and cause large ischemic strokes. Prevalence is increasing in our country, and as our population ages, the problem with atrial fibrillation gets increasingly more. 5% of patients under 65 years and 20% of all individuals 80 years or older have atrial fibrillation. Lifetime risk of AFib is about 1 in 4, 25% for people over 40 years old. The thing about atrial fibrillation and stroke is that it accounts for about 15 to 20% of all stroke cause. And people who have a stroke related to AFib, or what we call cardioembolic phenomena, are much more severe and disabling. This is a picture of a large vessel in the brain called the middle cerebral artery, and the right M1 is totally blocked, and this most often is caused by a cardioembolic phenomenon. Sometimes it could be a thromboembolic phenomenon from the carotid. And this is what happens if that blood vessel is not recanalized or opened. You can have a large amount of brain tissue. All this white area is brain tissue that will likely not survive, and then you end up with a large whole hemispheric stroke. As I said, as our population is aging, we are having increasing amount of atrial fibrillation. Now, this is another way of looking at it. As our population ages, we have increasing number per thousand. Anyone can get AFib, but it's usually as we age where we're more likely to have it or develop it. It's again 1 in 25 people 60 and older, 1 in 10 80 and older. 2.2 to 2.25 million Americans, estimated that 460,000 new cases are diagnosed every year, and it's a tremendous problem worldwide. So what is it about AFib? What are the other common comorbidities? And this is again what I wanted people to think about. Hypertension, ischemic heart disease, hyperlipidemia. Top of the list, whether the person's below 65 or above 65. Diabetes is also on that list. And, thinking about how do we best affect and prevent patients from having stroke, these are our targets basically. We know that, right? So how do we tackle that? How do we get it all together? And of course, again, it's educating our community, because there's misconceptions about, if it's permanent AFib or paroxysmal AFib, and well, if it's paroxysmal, I'm not as much risk, and we know that's no longer true. We maybe thought that 15 years ago, but that's absolutely not true. And what is it that's so dangerous about AFib? As I said, it's a more devastating stroke, and more likely to have a death from stroke when you have AFib. So if you think about the map I showed earlier, related to stroke death rates and underserved communities, now look at the atrial fibrillation hospitalization rates, and it almost mirrors on top of that previous map. These are the areas where we can make a big difference, is helping not only us as providers better understand the stroke risk assessment scales used in atrial fibrillation and stroke prevention, but also even getting out to our community so people realize there are ways to assess their risk of stroke, and there are definite things that can be done to help prevent stroke relative to anticoagulation or even antiplatelet therapy and managing all the other risk factors. Again, this is just what we call a dense MCA sign. This is a large clot burden in a left MCA. What we might see on a CT perfusion scan is this type of phenomena where the volume and the flow seem to be okay, but there's a big perfusion deficit. And in those scenarios, at our comprehensive center, we would go and do a neurointervention and find the blood vessel that's not flowing and open it up. So, and I think Jim's going to talk to you about what we're doing in the pre-hospital setting, but this is an area we're really excited, and I think that it's a big potential for university best practices as well to try to harmonize and synergize the EMS systems and get everyone thinking about how we're getting people to the best place to get their care, so we're saving time and we're able to deliver therapy to save as many brain cells as we can and have the best outcomes possible. So,
Before we shift to
Jim?
Jim, I just want to ask you one question, and that is, can you help us focus a little bit on how we can educate the patients at highest risk for heart attack and stroke? So what we've discovered through the University Best Practices, the Right Care Initiative around the state, is none of the systems have in place specific education programs for patients who have been designated at high risk for these devastating events.
So, I mean, it starts with identification. So you're saying that people that are identifying, right, how do we provide them with the necessary tools and education and services, right? It's going to tie into a little bit what Jim's talking about with our remote monitoring program. But it's a difficult challenge. There's lots of things that we should be doing, but we're not. I think we have an idea that we have education tools in our electronic health registers. I'm sure everyone has these. We print them out, we hand them to the patients and their families. They're really not as effective as we think they are, and that's the reality of it, right? We need something where we can, provide better in-between care, make it more tangible, make it more effortless for patients and their carers, their family members, to understand and make sure that they do the right thing for themselves. We see it over and over that someone stops a medicine because they weren't sure what it was for, or they stop a medicine because they think there was a side effect, but they didn't bother to reach out and try to get informed. I'm hopeful that, with portals and other type of technology, that we are going to be able to do a better job. It just hasn't been realized yet, as far as I can tell.
I look forward to appreciated your talk, Mr. Maloney. I might be able to go on a bike ride with you, but maybe just for the first 30 miles. That's about it. I'm going to drill down a little bit more into the weeds. As the director of the Dignity Health Telemedicine Network, my job is to get the specialists up the bat, to get into the bedside virtually. So I'm going to kind of give you an idea of how things work. Let me back up a little bit in terms of the DHTN, the Dignity Health Telemedicine Network. We were founded in 2008 as the Mercy Telehealth Network. Dr. Schatzel mentioned that Deidre Wentworth was giving a community education program and was able to get some donations from the Elliott Foundation. Dr. Schatzel did not mention that he's one of the founding members of the Mercy Telehealth Network. And as was mentioned, one of his specialties is sleep medicine, but he doesn't sleep much. He's been very dedicated to this cause for the last many years. We have, in 2014, we were recognized as the Dignity Health Telemedicine Network. We have over 80 endpoints now. Sometimes we call them robots. I have a surprise for you at the end. This is where the technology comes in, getting the doctor virtually to the bedside. Over 52 specialists, 11 different services, 48 partner sites, and as of December, we did over 17,000 consults. 5 years ago, we did 115 consults in that calendar year. So you can see the rapid growth, and this is several of our services. This is our footprint across California and now into Nevada. Which pointer word? Everybody always hones in on Hawaii, and I said, okay, where were you when I was driving through the desert in Southern California? Everybody likes to help me in Hawaii. But we're up to 48 partner sites now. And of those 48 partner sites, 30 of them were providing telestroke services. And as of December, we did almost 6,000 consults with a 2-minute response. That means when the partner site contacts us, the neurologist is virtually at the bedside in 2 minutes. How amazing is that? Let me go through the process. I want to drill down so you kind of get an idea of what happens at the bedside. So the partner site activates a stroke alert. And we say 5, 5, and 5. Basically what that means is 5 minutes to rapid medical assessment by the ED at the bedside at the partner site. Then 5 minutes to get that patient to CT on the EMS gurney. 5 minutes to activate the call the Dignity Health Transfer Center to activate the teleneurologist to call back. So they will call back their page, they call back to the partner site, then they beam in, we say beam in, they get on their control station, which could be an iPad, even an iPhone, a desktop or laptop control station, and they will virtually then get to the bedside. So the consult is completed in collaboration with the partner site physician. So the ED physician usually is there at the bedside with the telestroke neurologist who's having a conversation around the care of the patient. They will make a decision to transfer if necessary. And then I'll talk briefly in a few minutes about the rapid transfer process. And then if they need to transfer, we have a way of getting the information back. And appropriate transportation is provided at the partner site. And the receiving hospital verifies there's a bed, and there's a rapid transfer information is provided within 15 minutes.
Jim,
Yes?
about what percentage of patients need to be transferred, just to put it in context for
About 15%.
15?
Yep. Our goal is to keep the patient in their community. But as you will see now, there's a different standard, so if we need to, then there's an ability to transfer them quickly.
Prior to our virtual connections with most of our partner sites, we were transferring 30 to 40%
Yeah.
of patients.
Yeah,
Because sight unseen, you can't, you know.
well, and they didn't feel comfortable in treating them anyway. They didn't have a neurologist to
Right.
hold their hand. So, Mr. Brown?
Yes.
Could you go back to the
Sure.
California?
Yes.
So doesn't Sequoia Hospital does not have stroke doctors?
It's a good question. We provide stroke care to hospitals that they may have a neurologist, they may not. So think about it. If you need a doctor at that bedside within minutes, if the neurologist is sleeping at home and there's a stroke alert activated at 3 in the morning, they call in. They may be able to look at images. They may be able to look at labs. They can't see the patient. But if you have somebody on call, and as I mentioned, we're at the bedside within less than 15 minutes, we're going to call back within 2 minutes, now you've got eyes on that patient. So then the community neurologist is able to come in maybe in 30, 40 minutes and follow up with that patient. So the idea with telemedicine is to get somebody there rapidly to the bedside.
Yeah, and a lot of neurologists don't like taking call, and call requirements for EDs are highly variable across the state. You might have neurologists in town that won't do call, right? So this solves those issues.
So there was a slide in my deck about recruitment and retention of physicians. So Sequoia is one of the best case examples of that. So they had neurologists on staff. None of them were stroke neurologists per se or subspecialty trained in vascular neurology. They had an opportunity to recruit a vascular neurologist out of UCLA's program. One of the contingents was you must have a telestroke system in place so that weekends, holidays, when I'm not available, I'm running the stroke center. I want to make sure there's seamless, continuous coverage for any patient who lands in this hospital. So that's one of the reasons why we got installed there about 2 years ago, because that neurologist they were recruiting wanted to have this type of service kind of backup. You know, they're there during the day and they run stroke codes during the day, but you can't be there all the time, 24/7. And that hospital doesn't do neurointervention, so we collaborate with Stanford University, where all the neurointerventions are transferred to if someone's a candidate.
So that was an important point. All of the patients don't have to be transferred to here. You know, somebody in Oxnard shouldn't come here. They should go to UCLA. So again, it's really what's in the best interest of the patient to the closest comprehensive center. And that's what you guys do.
Yeah. We've coined the phrase 5, 5, and 5. Again, rapid medical assessment by the ED physician, CT on the EMS gurney, and then activate telestroke. So as we've talked about, the idea is to keep the patient where they are. And if you can provide TPA, recommend TPA, and keep them there, that's the best. Although we know now there are over 7 clinical trials that show endovascular reperfusion therapy is a standard of care. So if that patient's going to need to be transferred, now you have to activate a way of getting to the center quickly. So we call this the rapid transfer process, and you get to see my animations. So the partner site doctor and the teleneurologist agree the patient needs to be transferred. In our process, the teleneurologist calls back to the Dignity Health Transfer Center and says, activate rapid transfer process. The transfer center knows which transport provider is closest to the partner site hospital, and they will say go. We've taken out, let's see if we've got a bed, we just say go. And so while they're sending the transport provider to that partner site, the administrative nursing supervisor at the receiving hospital is making sure they got a bed. So the closest helicopter in this situation transports the patient. And we do the same thing with the ground transport. In fact, at several hospitals, we actually station a critical care transport vehicle near that hospital so that if there's a stroke alert and they do need transfer, they can rapidly transfer the patient. Part of this process is communication. So if Dr. Schatzel, who's doing teleneurology, wants to talk to the neurocritical care specialist or the neurointerventionalist, he can use this secure texting system to provide information back and forth. And to drill down a little bit on the process, here you see Dr. Schatzel at the workstation. That's a really old photo. Beaming into Deidre Wentworth, and I'm the patient there, doing the assessment, creates his note, signs his note, electronically drops into the partner site EMR. One of the tools I'm quite proud of, and a lot of you are familiar with the stroke, you're familiar with the stroke timeline reports. We've actually automated this, and so if I can point here, actually maybe I can point here, yeah. So watch my pointer. When the patient hits the, I know I got 5 minutes. When the patient the partner site calls the transfer center, this gets timestamped. So you see these different things that need to happen at different points along this timeline. When the neurologist is doing his or her consult note as they're doing their consult, these things get timestamped on here. So then you can see the difference in time. So look at this, the actual time here, 11:26, and then the actual time TPA was recommended, 19 minutes later. A lot of times patients are still sitting in the ED in the waiting room in 19 minutes. Now imagine, and we use this for our, and I'm going to jump ahead here, this is just some stats. So now imagine a patient in Kern Medical Center, Tehachapi Hospital, Shasta Hospital. That patient is quickly connected to the teleneurologist, gets this kind of information, gets this recommendation to the partner site so they can be treated. And this is just over time, 2013. You saw our volume was a little over 1,000. And our push to these partner sites is very tall order. Get their go-to-needle times less than 60 minutes. Here you see in 2014, 2,200 consults. 2015, 4,300 consults. And a 2-minute response time, door-to-needle time. 63% of them got it less than 60.
Jim,
Yes.
for the partner sites, you do a bunch of training for them so that they can do this, right?
Yes.
You don't leave it up to catch as catch can.
No, and that's a really good point. Part of the success of telemedicine is the connection to the partner site. The nurse and ED physician have to know what to do on their side. So it's not about just beaming in and giving advice. It's about knowing how to assist with the assessment, the NIH assessment, how to deal with the orders that are given. So I'm going to go across and continue real quick. And I think I got 5 minutes left?
Yeah.
Okay. About 40% of the people who suffer a TIA and an ED are high risk for stroke. Typically, we say, you had a TIA, you're lucky. You didn't have a stroke. Go home. We need to, part of this initiative, we need to be all over those patients. We need to capture them. They're at very high risk. So one of the things that we have done in one of our areas, this happens to be in San Andreas, it's actually a pulmonary consult, but for visualization, you can kind of get the idea. Now we can follow up with that patient. This particular patient was seen in the ICU and now followed in the clinic. This hospital reported a decrease in their readmission rate from 16% down to 5% in a year's time. So now to get into how do we help the patient sort of manage themselves, and we have this proof of concept program, and actually it's a GE and Intel product we've been using. And this is the criteria to get into the program. Real simple, we've developed this package. The patient gets a box. It has the tools in it. Little iPad, blood pressure cuff, scale, oximeter if needed, and a deep flow device if needed. So the patient very simply takes their vital signs. It actually Bluetooths to this device, goes, you remember this, James, goes into a dashboard that the nurse is able to look at. And in this case, the nurse here is monitoring me in this example. It looks at the dashboard. So it can look at maybe 100, 150 patients and sees how's the patients doing in relation to their parameters. And we can have a video visit in this case. Again, this is very low end. This is just a proof of concept. We saw with these patients that were high risk for stroke a dramatic decrease in their hospital length of stay from 1 year before, 1 year after.
And these are TIA patients,
These are patients that could be at risk for stroke.
but they're not.
Not exclusive TIA. Yeah.
But it is an interesting idea to do a specialized focus project
Yep.
on TIA patients.
Yeah, one of the things that
So what's the question?
it would be a good idea to specialize.
So yeah, just when Jim mentioned TIA patients earlier, I misspoke. When people have TIA, if they come to any of our hospitals in this community, typically they're going to get admitted because TIA is a tissue diagnosis. That changed about 3, 4, 5 years ago, where patients need to go through a very rigorous pathway with an MRI, carotid duplex, echocardiogram, cardiac monitoring, and then they might be able to be released after 24 to 36 hours. But they typically go through that very rigorous pathway, which is different than it was 5 or more years ago.
Does that change that 40% risk by them getting admitted?
Yes, it does. I mean, we know what the risk is. If we don't do all those things, then someone's likely going to come back with a completed stroke. So that's why we identify all the things that potentially puts them at risk for a recurrent stroke, and we implement all secondary prevention measures before they leave the hospital, which includes antiplatelet therapy, lipid lowering medication, anticoagulation if we find that they have a smoking cessation, exactly.
So what he was saying is, in the average population of people who've had a TIA, 40% risk. When you do that proactive program, how many of them go on to have a stroke?
Well, we reduce the risk significantly. It'd probably be less than 5. I mean, there's still a risk of recurrence, but we dramatically lower it by implementing all these secondary prevention measures.
Were you going to say 5%?
I was going to say around there.
That-
Just coming off
So
the top of my head.
that's motivational. Like, there's something concrete we could do by about how many TIAs do we have in Sacramento a year? Because we've got a much higher rate of stroke here.
Yeah.
Yeah, the challenge with this population is pretty much already dialed in. If you're looking for a
So
target,
recognize.
right? Well, if they come into the emergency room,
Right.
yes. But if they're not, if they're having a TIA at home and not coming into the system, you're right. They're absolutely unidentified.
And that's the whole thing about the educational stuff is that, and we talked about this, maybe it was last time, about how these symptoms are a red flag, and you need to drop everything and get to healthcare, period. You know, you think that you might have a little TIA, or you think you might have a stroke, go have it evaluated, because that's what's gonna save brain.
That's,
You know, and people don't do that. Oh, well, maybe it'll go away, you know, it's all of those things. And it's that public health kind of approach where I think that this is a public health campaign.
So the reason I first asked the question was because of the population of TIA, and they're getting this program, getting admitted and getting dialed in. There's an opportunity for other patients besides just the TIA patients, because it sounds like you have other risk factors, and identifying those for this particular program you're discussing, it sounds like there's a real good opportunity here.
And keep in mind, not everybody has that high standard across the country. So I've been in partner sites where I said, we talk about our program, and they say, we have the best rehab program when you talk about stroke. And I felt like I was going back 30 years in healthcare. So you need to be proactive and catch them. I'm just going to mention three things, a couple more things. Joint Commission has 3 levels of accreditation: comprehensive or acute stroke-ready hospital. This is a program that rural critical care hospital can go through to get stroke-ready, and it just came out last summer in July. Primary stroke centers, and many of our partner sites have become primary stroke center, and then comprehensive stroke center as Mercy San Juan is. Just to kind of, again, underscore what Dr. Schatzel said, that there's this ecosystem, and if you can create it by connecting the doctor to where the patient is, you can get the best care literally anywhere. This is a very interesting slide, and it shows the last quarter of some data that actually Dr. Schatzel shared with me. This happens to be Mercy San Juan's percentage of getting patients door to needle time of less than 60 minutes. This is an average of all the comprehensive stroke centers in the country. This is the Dignity Health sites that we provide telestroke services to. So you can see that we're even beating the comprehensive stroke center average across the country, at least in this quarter.
Cool.
I think I'm out of time.
So I think it's up to the group. Do we want to just have a round-the-room discussion, or do we want to learn a little bit about their mobile stroke unit? Another 5 minutes for
Okay.
Jim, and then we'll do 5 minutes around the room.
Okay.
And
So there are a few models around the country, around the world, where they have put CT scanner in an EMS unit, they have put neurologists in an EMS unit, they have put the laboratory in an EMS unit to try to treat the patient at the site where they have discovered they have a stroke. The process is they treat the patient, they may have the neurologist in the unit, they have a radiology connection and so forth. The cost of this is very high. Just a single unit might be $1.5 million. The other chance of you being in the right location with this unit is kind of far-fetched. Think about it. So we've actually initiated a little pilot in Folsom. We got some grant money again from the Elliott Foundation. And we put these devices, looks like that, or looks like that. We actually call that the headbanger unit because we put them in the wrong place. EMS personnel, we didn't know that. Yeah. So what we did was we moved it on the back of the door. So what happens is when the EMS is activated, our teleneurologist will be activated. They will beam into this device, be at the foot of the bed. The EMS personnel are still doing their thing, so they don't have to do anything with this device. The neurologist is there over the shoulder doing an assessment of the patient. And we were looking at some data just recently, and we noticed this is when we started back in the summer. Median of the stroke to onset of needle, here we saw a dramatic decrease in time. This is when we started the program. Folsom reported a couple weeks ago a door-to-needle time of 18 minutes.
Wow.
So the physician, the neurologist had beamed in, saw the patient, did the assessment, right to CT, right to TDA. So this is my last slide. It's just it's a 2-minute little video for you to watch.
My husband had a stroke during the middle of the night, and I didn't know it was a stroke, but I did call 911, and they took him immediately to Mercy. Within 20 minutes of sitting next to my husband, a robot appeared.
I have no recollection of all of that.
The nurse simply said this was part of what they could offer, and I was thrilled because a neurologist was able to give up-to-date information and examine Tom directly and make those decisions that saved hours, perhaps, and perhaps saved the quality or life itself for Tom.
It was crucial that the neurologist, the other end of the robot, was able to provide the input he did.
That technology helped bring him back to full health again.
It was a part of the overall wonderful care I received. It was just a part. Important.
That's it.
So you said that typically a outfit of the EMS unit is $1.5 million, but you were able to do this for a fraction of that, right?
Yeah, it's better. What we're doing, we don't have a CT unit, we're not doing labs, we just have to lay the eyes on a physician in the EMS, in the first responder EMS unit. Yes?
Jim, with that, because some of the patients, there are certain things that would indicate that it's a high risk of needing neurointervention. Do you do that assessment and then divert them to a comprehensive center where neurointervention can be done yet?
No, that's happening in some communities around the country, but not in our
Not yet.
community here, no. But there's a new, everyone knows like the FAST scale, face arm. There's a new scale called RACE, where they can try to identify a large vessel occlusion, which would then, they would have a protocol where they would go to the place where the patient would benefit from the neurointervention.
So
That's happening in the community.
again, it saves time to get to the definitive therapy. Because if you're out in Folsom and you maybe have a high score, they don't take it at Folsom. Take it to St. Honor.
I want to take a moment to just ask Dr. Janet Bates to stand up, just so everybody knows who she is. We will schedule her for a future presentation. She runs the stroke program for the California Department of Public Health within the chronic disease branch, and has recently received a Paul Coverdell grant for California, and we can think about possibly doing some sort of pilot related to that, and we'll have her come back. Sorry, the time was a little shifted
That's
today.
just fine, this was well worth it. You mentioned public health, here we are.
Yeah, that's what we're talking about, take care of the whole population,
And-
and really do that stuff. So.
Mary Rusev, would you stand also? She's the head of their public communications group, and she has done remarkable work in the tobacco program. You all know the amazing impact we've had in California in reducing smoking. It's because of the quiet heroes in the background working.
Correct that for a second. I was the other huge marketing campaign for NEOP, the Nutrition Education Obesity Prevention Program. But we always partner with tobacco. Thank you.
Thanks. Well, now I know who's gonna do the big TV ad campaign.
Liz Helms?
I have a question. When you were talking about TIAs, so follow-up and shortages of physicians, could you kind of give me an estimate from the time someone would leave the hospital with a TIA, not stroke, to be able to follow up with either with the neurologist? Are there any wait times? Because I'm hearing really long wait times, 2-3 months from people.
So in our system, because we're a comprehensive center, we have to get people in very rapidly, so we're developing TIA clinic and all these type of things. So we try to get someone who landed at our hospital with stroke symptoms that resolved, MRI didn't show evidence of an ischemic stroke, implemented all secondary prevention strategies. We try to get them into our vascular neurologist within 2 weeks. That's our goal.
Within 2 weeks.
Oh, be a robot, be a telemedicine.
No, it's physical visit.
Okay, so, all right, so.
Real.
That's our goal.
So one of the things that, I think that you told me this, how many neurologists would it take to cover the 40, or the 30 hospitals, with acute telestroke? How many would it take, and how many do you have, to have them in that town, and how many do you actually use?
So we have 15 neurologists that do this type of work. So we do 3 shifts a day, 3 8-hour shifts. Typically, you need at least 3, maybe 4 active staff neurologists in order for a sustainable program where you're basically not on every night or every other night. So, the math is basically between 90 and 130, 40 neurologists to do the work that 15 neurologists are doing through the telemedicine network.
That's how telemedicine leverages your assets. That's the story right there.
So to answer Liz's question, the person gets follow-up after TIA how quickly?
Our goal is to get them in within a couple weeks to the vascular neurologist. They certainly need to get to their primary care doctor within a week of discharge. That's the typical instruction. And we try to give them instructions 2 weeks with the vascular neurologist.
I know everybody has questions in this room, but one idea I'll throw out for you to comment on is, does it make sense to have some sort of a protocol for patients doing something like this pocket card that we've done for hypertension, for AFib, for TIA, I don't know. Is there an opportunity here for clinician education across the community to help with those high-risk patients?
Yeah, there's definitely opportunities for clinician education to try how to engage your patients better, how to better inform your patients, how to activate your patients. It's a big gap in our system, to be sure. We're good at identifying one or two things, but not understanding the total risk assessment of someone's cerebrovascular, cardiovascular disease.
I just wonder if somebody saw their PCP as opposed to being seen in a TIA clinic, what difference it would make in the outcomes.
That's a good question. The way we develop our vascular clinic is we access to more immediate resources that a primary care might not. Not every primary care office has a primary care medical home built around them at this point. We got to get to that point. It's not available yet. Whereas our disease center of excellence has focused attention. We have all the things that we need in that clinic to make decisions about that patient. We have access to imaging, we have access to the lab work from the hospital, we have access to everything. That might not be available to all the primary care doctors, especially in a hospital where we take care of everyone. It's not a closed system where they're all kind of belong to the same system. We take care of anyone who comes, and then we try to offer them all the same services regardless of who's paying.
So you talked a little bit about the CHAD2 and the CHAD2 Fast or whatever the other one is. Have those been automated, like on an app where physicians can have access to them?
Yeah.
Okay.
You can get them in the App Store. You can get all kinds of risk assessment tools.
No, we know the cardiovascular risk calculator, but that specifically for stroke risk is.
CHAD2 and CHAD Fast is in the App Store.
Well, thank you so much, you guys. It's a great story.
Just before you leave, we want to make sure that you all know that our next University Best Practice is April 11th. And Dr. Jim Schultz, the CMO from San Diego Neighborhood Health Community Clinic, will be joining us. And we hope you can be here. We're going to do a little presentation on our combined Hill SIT Dr. Earl survey. And moving right along with that, and hoping we can get other groups to join that survey as well.
So we also want to flag that our May meeting will be the May 2nd as opposed to the second Monday. Our room got switched on us, so that's just a little bit out of cycle. People don't necessarily read their email, so just we have our habit, and we love to meet with you every second Monday of the month, but in May we'll have an exception and meet on the first Monday of the month. So thanks everyone, and let's do a special thank you to Sean Maloney for that amazing.
Telehealth, I mean, do you do it around other ailments that I've had a bit more than just primarily around stroke?
So we do stroke, critical care, we're starting cardiology, not STEMI cardiology, but more like clinic cardiology. We do pulmonary clinics, infectious disease, pretty much any service